All right, welcome to The Explainer. Today, we're doing a clinical deep dive into cellulitis. It's a common bacterial skin infection, for sure, but it can get serious fast. We're going to cover the whole spectrum, from what causes it and how we diagnose it, all the way to management strategies and its most dangerous complications.
So here's our game plan. We'll start with the basics, what cellulitis is and who's at risk. Then we'll get into the real challenge, diagnosing it and figuring out the culprit pathogen. After that, it's all about treatment and prevention. We'll also tackle the big one, necrotizing fasciitis. And we'll wrap it all up with a quick case review to make sure these concepts stick.
Okay, let's kick things off by getting a really solid clinical definition of what cellulitis actually is. So, at its very core, cellulitis is an infection that gets into the deeper layers of the skin, the dermis and the fatty tissue right underneath. Just picture a patient walking in. They've got this patch of skin that's red, that's the erythema. It's swollen, it's warm, and it hurts. And crucially, it's spreading. That's the classic picture we're looking for.
Now, one of the first things you have to differentiate it from is erysipelas, and the clue is right there on the physical exam. With cellulitis, the borders are fuzzy, they're poorly demarcated, kind of blending into the normal skin. But with erysipelas, which is more superficial, up in the upper dermis, the borders are sharp, they're raised, you can practically trace them with a pen. That distinction is a classic clinical problem.
So, what lets this infection in? Well, you need a break in the skin barrier. That could be something obvious, like a cut or an ulcer. But it can also be subtle, like the tiny cracks between the toes from athlete's foot or tinnipedes. And here's a huge one, edema or swelling. If you have underlying lymphedema, your local immune system just can't keep up. It's a massive risk factor, especially for recurrent infections.
So, you can often spot cellulitis clinically, but here's where things get tricky. Identifying the specific bug causing the problem is a whole other challenge. This brings us to diagnostics and the trouble with pathogen ID. And this is the million-dollar question for any clinician at the bedside, right? You see the classic signs, you know it's cellulitis, but what bacteria are we fighting? You'd think finding out would be simple, but it's really not. And here is the central problem. Our usual tools, things like a needle aspiration or even a skin biopsy for culture, are shockingly unhelpful most of the time. They usually come back negative. Why? Because in a simple case of cellulitis, the bacterial load in the tissue itself is just too low to be picked up by our standard methods.
And get this number really drives the point home. If you run blood cultures on a patient with uncomplicated cellulitis, you'll get a positive result less than 5% of the time. The yield is incredibly low. That's why we don't do them routinely. It's just not cost-effective, unless, of course, the patient shows signs of a systemic infection.
So, what does all this mean? It means we can't afford to wait for culture results that probably won't tell us anything anyway. Management has to be empirical. We have to start treatment right away, targeting the usual suspects: beta hemolytic strep, which is the most common, and Staphylococcus aureus.
Okay, so that brings us right to the next logical step. How do we actually treat this? How do we pick the right antibiotic? And just as important, how do we stop it from coming back?
All right, let's look at the treatment playbook. It's really stratified by severity. For a straightforward, non-purulent case where we're pretty sure it's strep, a simple oral beta-lactam like cephalexin is usually enough. If it's more moderate or severe and they need to be hospitalized, we'll step it up to IV therapy, maybe with cefazolin. Now, if the case is complicated, if there's pus or the patient has risk factors for MRSA, we have to bring out the big guns. That's where drugs like daptomycin or linezolid come in, often as alternatives to vancomycin.
Now, what about those patients who just keep getting it over and over again, especially if they have a known risk factor like lymphedema? For them, we have to consider long-term antibiotic prophylaxis to suppress the infection. If we know it's strep causing the problem, long-acting benzathine penicillin G can dramatically cut down on how often it comes back.
You know, antibiotics are just one piece of the puzzle. To really stop this from coming back, we have to go after the root causes. It's about proactive prevention, not just putting out fires.
So here's a simple 3-step strategy for prevention. First, you have to manage those underlying conditions. If there's lymphedema, get them into compression therapy. Second, hunt down and eliminate any entry points for bacteria. That means treating that athlete's foot for good. And finally, for those high-risk patients,
Use the long-term antibiotic prophylaxis we just talked about. This is how you break the cycle.
Okay, now we need to talk about the complication that every clinician dreads. It's rare, but it's so devastating that you have to have it on your radar at all times.
We're talking about necrotizing fasciitis. And I want to be crystal clear. This is not just bad cellulitis. It's a whole different beast. It's an incredibly fast, flesh-eating infection that tears through the deep tissue along the fascial planes. This is an absolute life-or-limb surgical emergency.
The clock is ticking from the moment you suspect this. Survival is directly tied to how fast you recognize it and get the patient to the OR for aggressive surgical debridement. Antibiotics are critical, but surgery is what saves them. Imaging, especially an MRI, can be a huge help in seeing how deep the infection goes. And you have to be extra vigilant with kids, where the signs can be a lot more subtle.
Whew. Okay, that was heavy. Let's take just a quick breather. A little microbiology humor for you. Why did the bacteriologist break up with the microbiologist? Because they had too many cultural differences. All right, let's pull it all together.
All right, let's put all this knowledge to the test and see how it works in practice with a quick review.
First question for you. Which of these features is least characteristic of cellulitis, especially when you're comparing it to erysipelas? And the answer is C, those sharply demarcated elevated borders. That's the calling card for erysipelas. Cellulitis, remember, is deeper, so its borders are indistinct and blend in.
Okay, next one. What's the main reason we don't usually bother with cultures in a simple case of cellulitis? The answer here is B, limited diagnostic yield. As we saw, you get a useful result less than 5% of the time. It's just not worth the delay when we need to start empirical treatment anyway.
And for our last question, which of these is a severe complication of cellulitis that demands aggressive, usually surgical management? That one's gotta be C, necrotizing fasciitis. The others are risk factors or features of the disease, but necrotizing fasciitis is the true surgical emergency we have to watch out for.
And that brings us to our final and maybe most important question. We rely so heavily on these empirical treatment models, but with antibiotic resistance on the rise and our diagnostic tools coming up short, is that sustainable? How do we need to evolve our approach in the next decade to stay ahead of the curve? Something to think about. Thanks for joining this explainer.